A very good afternoon to all of you. I'm very happy to be here and talking to you about two very important aspects of nucleus management. The first would be the soft cataract. Can we have the slides, please? So the first challenge that we face is that these patients are usually younger and they have an elastic capsule. So forceps might come in handy as compared to a cystotome in these patients. The second problem is during the phacoemulsification. In harder cataracts, we tend to use higher vacuums, and they give us a good hold also because of the density of the cataract. It's easier to hold them well. Whereas the softer cataracts, we tend to use lower vacuums, which leads to a poorer hold, and also because of the density of the nucleus, it's more difficult to hold on to them, and this leads to difficulty in chopping. These patients also have a sticky epinucleus, which makes it very difficult for us to pull the nucleus towards the center and operate in the central safe zone. Therefore, there's a tendency towards operating in the peripheral zone, which leads to a posterior capsular rupture. So let's look at a few surgical videos here. This is actually a case of a high myopic patient who's planned for refractive lens exchange as he's unsuitable for ICL. So we can see that the capsule is a little elastic, although I managed to complete the rhexis with the cystotome itself. Hydro procedures are extremely useful and our best friends here. We need to do a good hydro dissection and delineation. And what I'm trying to do here is just lift up one of the poles. So I've just lifted up the pole just with the hydro. And this makes it very easy for us to emulsify these soft cataracts because we just need more of a vacuum and we hardly need any phaco power. Now I'm finding it a little difficult here to lift up this last fragment. So what I'm doing here is again gently just lifting it up. We can either use viscoelastic or a little bit of hydro we can do again, and then lift it up and bring it to the central safe zone, and now it can be emulsified with ease. Now since this is a high myope, before I come out of the eye, I'm injecting viscoelastic to avoid chamber fluctuations, followed by an irrigation aspiration and a lens. Now, sometimes, the hydroprolapse is not possible, or the nucleus density might not be as soft as I showed in the first case. And these cases, what we can do is, because the epinucleus is so sticky, it makes it very difficult for us to actually lift up this nucleus up. So first thing is that, of course, we need to do a good hydro delineation, which would free up the central nucleus. And what we are doing here is we are just rotating this lens, going all around and removing this sticky anterior epinuclear plate. This technique in my hands works really well. If I remove the anterior epinucleus and the cortex well, then what we can do here is just lift up this entire nucleus with the help of our chopper, because there's nothing holding on to it now. And this can be emulsified with ease now. And again, because we are not using much of a phaco energy here, even if we are a little anterior in these soft cataracts, we are not very bothered about the cornea. And this is another case, and I'll show you the technique of stop and chop in these softer cataracts here. So here, this patient is planned for stop and chop. Again, I'm following the same principles of first removing the anterior epinucleus here, rotating it and going over so that I can free up this nucleus and makes it easier for me to further chop. Now, the trench here doesn't need to be too deep or too wide. If we make it too wide, again, it will make it very difficult to hold on to that soft lens. So we just make a relatively shallower trench, or narrower trench, as we would make in harder cataracts. And now again, freeing up this nucleus from the epinuclear plate becomes easy, and we can go ahead with all our chopping maneuvers. So stop and chop also comes in handy for few of these patients where the nucleus is not soft enough, or you don't want to do a hydroprolapse, or the rhexis is not big enough for us to prolapse one of the poles out of the bag. So I'm going ahead with the chopping, and then we'll clean it up and implant an IOL in place. Now, my last case here highlights some of the difficulties that we face in these softer cataracts. So again, the plan here is stop and chop. I'm going ahead with my trench and then dividing this into two. Now, what happens here is that because the nucleus is soft, we are just splicing through this cataract, and there's a tendency towards formation of a bowl where we try to hold on to the lens and just gives away. So this is what the difficulty I'm facing here. So when this happens, decrease the amount of energy to as low as possible, maybe 2% or 5%, increase the vacuum. So I'm using about, now I've increased my vacuum and made it about 450 millimeters of mercury, and then hold on slightly more anteriorly and grab one of the poles and grab the lens fragment here, so that gently and slowly, if we keep applying vacuum with very low power, if we can just get one of the heminuclear up, then we can, rest of the surgery becomes very easy and we are able to go ahead with this. So this case highlights what to do when we have a formation of a bowl and how to come out of it. And this is the end of the case. This is my last case that I would like to show for this talk, and we'll go on to the posterior polar cataract. Now, posterior polar cataracts also tend to be a little softer, and there are certain things that we need to keep in mind when we are dealing with posterior polar cataracts. So, here, this is a patient who has nuclear sclerosis with high hypermetropia and pterygium. The two important things in biometry that we need to look at is the aqueous depth, which is adequate, and the amount of astigmatism. This is why this patient is planned only for a cataract surgery and not a pterygium surgery planned subsequently, followed by a cataract surgery here. So the patient is not bothered about the pterygium, he just wants visual rehabilitation. That's why we are not combining it with the pterygium surgery. Also, that could be an alternative here. So the rhexis in these patients, when we are talking about posterior polar cataracts, needs to be of adequate size, 5 to 5.5 millimeter, not too large, just in case we have a PC rent and we need to do an optic capture. We have to avoid hydrodissection, as we all know here. So what I alternatively do is that I use viscoelastic, very small amounts, and I just go underneath this anterior capsule and inject very small amounts of viscoelastic. What this does is that when I'm doing a hydrodelineation, it prevents an inadvertent hydrodissection, so that the fluid wave cannot go in the area of the hydrodissection, because we have created amount of resistance here. Now, this is again, these cataracts tend to be relatively soft, and my plan here is to make a trench first and divide this nucleus into two. So this is the trench that we are going ahead with, and then we are going to divide. So while dividing the nucleus, we have to be a little careful not to apply too much pressure. We have to remember that posterior capsule can be very fragile in these patients. And now just lift up one of the heminuclei without much rotation, as less of rotation as possibly we can manage with, unlike the normal cataract where we rotate the nucleus. So just embed and lift and then further chop, so that we are avoiding the stress on the posterior capsule at all points of time. Another important aspect of posterior polar cataracts is that before we come out of the eye, we have to remember to either inject viscoelastic, because we do not want the chamber to collapse at any point of time. That itself can lead to a posterior capsular rent in these patients. Now what I do here is I inject some viscoelastic under the epinucleus. This does two things: helps in prolapsing the epinuclear plate, and also if there is a PCR, then that will plug the PCR and make it easier and safer for us to operate. So this epinuclear plate is being emulsified, and we can see that that posterior polar aspect of the cataract has come in with the posterior epinuclear plate. Then we are just using bimanual irrigation aspiration here to clean up this cortex. We should avoid capsular polishing in these patients. Even if there's a little bit of opacification, it is better to yag it later rather than to risk a posterior capsular rupture. I have enlarged the incision a bit because this is a 36 diopter IOL. This is a highly hypermetropic patient. So I want to I don't want to do a wound assisted implantation of the lens here. And before going in, I'm injecting a viscoelastic. Now, this is the left eye of the same patient. The initial steps are absolutely similar, the technique of viscodissection and then followed by a hydrodelineation, but the nucleus management is going to be slightly different for this eye, as this is a slightly softer cataract than his right eye. This is the left eye of the same patient. So as soon as I go ahead and trench it a little bit, I can just lift up this nucleus, and we are just prolapsing the nucleus and then emulsifying it with ease. So this is because these patients again have softer lenses. This could be a useful technique, and this again works very well in these patients. And then rest of the procedures followed are the same. We are going to remove the epinucleus by injecting some viscoelastic and placing the IOL. Now, my next case, I will just highlight a patient where we had a posterior capsular rupture during cataract surgery, probably pre-existing dehiscence of the PC. So, I'm making the trench here, and following the same technique, I have divided the nucleus. We can see it's a relatively soft cataract. I'm trying not to rotate the nucleus as much as possible, and then just, emulsifying the fragments. So this goes on relatively uneventfully, and we are able to do this very well. And then I'm going to inject some viscoelastic before I come out, and also to behind the epinucleus plate. So this is the viscoelastic going in, and again following the technique of viscodissection, and injecting a little bit. We do not need to inject too much of a viscoelastic because that could again stress the posterior capsule, just a little bit, so that it can seal the rent and also bring the epinucleus up. So till this time I am unaware that there is any issue, and now I visualize it here that there is a posterior capsular rupture right in this area. So I am injecting viscoelastic to just plug the defect. Important to inject viscoelastic before coming out of the eye. I am just using dispersive viscoelastic here and then going ahead with the vitrectomy. So we are doing a limited anterior vitrectomy, making sure that there is no vitreous in the anterior chamber, and injecting viscoelastic again before I come out. Then I shift over to my irrigation aspiration, bimanual irrigation aspiration once I have taken care of the vitreous. And I'm starting to aspirate the cortex away from the area where I've had the PCR. So I'm injecting, I'm removing all the cortex, away from the area of the dehiscence. And being very, very careful here, we might need to switch between the vitrectomy cutter or use the vitrectomy cutter itself to remove a little bit of the cortex. So if we feel that at any point of time the irrigation aspiration handpiece is not coming in handy and it's a little unsafe, we can just use the vitrectomy cutter, aspirate the residual amount of cortex and the vitreous cutting mode if needed. And then we are implanting a 3-piece IOL in the sulcus. Here the plan has to be changed. We need to have a backup of a 3-piece IOL when we are planning our posterior polar cataracts, because these lenses are safe to use in the sulcus. And again, checking for the vitreous, we can stain if needed with triamcinolone to see if there's any residual vitreous towards the end of the procedure. We can also use pilocarpine to see that there is no vitreous tag remaining and the pupil constricts well. And this is the end of the surgery. Thank you so much.